Good morning, everyone. We will get started. This morning, we have Dr. David Yan today. He is a chief of Otolaryngology at St. Luke's Health System, and we look forward to his presentation today. Thank you so much.
Great. Thank you for the kind introduction. Back in the day, it used to sort of be live by slides or die by the slides, right? I'm mature enough to literally remember being there in the middle of the night, with the camera on the thing, taking pictures so you can actually make physical slides. I think this morning was a little bit live by Zoom, die by Zoom. So for those of you joining remotely, hopefully you have a clear view. Please do chat or text in if that's not the case. For us here live, we have a little screen distraction, but we'll live through it, okay? So how did I find myself here? I'm not an expert in anything. You could just ask my wife and my kids, right? So how did I find myself here? About me, I'm willing to read, and I'm willing to listen, and I'm willing to learn, and I'm willing to think. And that's what I hope we can do with the colleagues here in person and remotely this morning. I made up the slide deck literally, right, in all senses of the word. And for a topic like this, it's pretty flexible. So I have some things to go over and share with you. I'm going to aim for trying to prompt some thoughts for maybe about 40 minutes plus or minus. And I do hope we do have some discussion. If not, I gave you a couple minutes back in your day. On the screen here, you can see University of Washington AI teaching series, as you all know, and that stands for Allergy and Immunology. But I don't think that any of us aren't going to think that AI, in whatever its manifestation or form, isn't going to impact us in 2025, let alone 2030. I will say I'm not ignoring that, right? You could say, oh, this is all going to be about AI because we're talking about our futures. But it's not, because that's a lecture or a conference or a course, or that goes well beyond. So I think it's important to think how that impacts what we're looking at. But I'm actually not directly looking or talking about AI per se on this discussion, okay? I got a ton of disclosures. None are really relevant to the bulk of this. Everybody wants to hide it, but as I admitted earlier, I like to learn and listen and think, and I'm willing to share that. And if you do so, you kind of end up getting a chance to work with a lot of industry partners, which I'm not embarrassed of. I think that's a nice thing, and I gather that there's some overlap in this realm. I would expect no otherwise out of UW. One of the reasons, there's many reasons I'm happy to come here. I said, how did I find myself here concretely? I want to acknowledge my friend and colleague Greg Davis, who was the rhinologist here at the UW for many years now. Now he's sobered up from straight line academics, and he's in private practice, if you will. But Greg was kind enough to introduce me to Dr. Len Altman. So thank you for having me. That's the concrete reason. I'm always happy to come back to your town for a number of different reasons. Some is this, the brilliance and the collaboration and what you have here. The whole ecosystem at UW is truly outstanding. I was last in any campus facility about a year and a half ago to complete an accelerator program that's through the Foster School Business Creative Destruction Lab. So I just want to acknowledge that as a really wonderful thing. So thank you for bringing back positive memories for me. Okay, so we're looking into the future, which no one can do. I said earlier that I'm not an expert at anything. I'm often wrong too, all right? And again, just ask my wife or kids, right? Okay, so I'm not an expert. I can be wrong, but if you're going to look in the future, you're allowed to do that, right? Look at meteorologists, right? They're teased. It's a meme or a joke about getting incorrect. But when looking in the future, you can never really know for sure. But the value of doing so isn't in getting it right or wrong. It's what it helps you do to prepare and think for the changes or what you think your future may be right or wrong, okay? So that's the value. And again, in practical perspectives, I hope there's learners here, other traditional learners, maybe fellows or residents or medical students. So this is probably a picture that most can recognize. This is, if you've never been there, well worth it. It's not Olympic, but it's beautiful and glorious, and it's its own way. This is the Grand Canyon, of course, and this is perched at the south rim, at the entrance or the exit of Bright Angel. Okay, so I don't have, I'm ill prepared here, so my mouse isn't really showing up here. I don't have a pointer per se, but across in the middle of the screen there, you can see going down in the canyon and out across to the north rim. It's about 23 miles or so. And so if you're gonna walk across and back, right, that would be an arduous pursuit. So if you're going to go rim to rim, I think it's important to plan, right? Because chances of you doing better with planning is a good thing. So that's also, this is the philosophical piece. That's also why we're here for planning and thinking. And one other thing I would say is if you're going to do that, you got to break it in pieces, right? It's one step or one part at a time. And if you look at our professional careers, and I see people here perhaps at different stages in their career, but what did we do with our history or our past in terms of our professional life? What were the pieces in terms of planning? Okay. This here is a simplification, but I think you guys can get the idea, right? If you look at your education, there's defined blocks: elementary school, middle school, high school, college, medical school, residency, right? So it's not exact. Is it 3 years? Is it 5 years? But we've been trained, brainwashed, programmed, taught to approach our lives in these blocks of 3 to 5 years, right? So you're going to train your whole career and then go out into practice and start doing the same exact thing for the next 30 years and you're going to be happy. That's not going to happen, right? So why am I itchy a few years in and looking for a new job or looking for new opportunity, new satisfaction? I've programmed myself to look up for change every couple of years, right? So I think that's a useful framework, which is exactly why I picked allergy and ENT in 2030. It's close enough in that maybe we can think about it and be correct or right or have it helpful for some of the things, okay? And then a couple years in, we're going to repeat the process and do the same thing to look towards the future, okay? So some topics that we'll cover. I just mentioned these 5-year blocks. Look at this picture here, okay, that I just nicked. Allergist report published by the American College of Allergy, Asthma, and Immunology. Okay, so when's the last time that you guys in the specialty of allergy did a cold, hard look at your workforce? All right. So I was poking around. I saw that there was a good workforce study or a pretty extensive workforce study done in allergy in 1999. Okay. Okay. In 1990 and again in 2004. Okay. Tell me what your cell phone looked like in 99. Tell me what your smartphone looked in 2004. Tell me what your car looked like in 2004 or you, right? 21 years is a long time. I saw an update in a publication, JASI, in 2021, but I didn't see any formal workforce report. So I think that if we're relying upon data back then or information back then, it's about as dated as the outfits and the hairdos in this picture, okay? But I think you look on our workforce, what does anybody think? You can tell this is in the past. Demand for allergists will increase 35% by 2020. Well, that was 5 years ago. Do you think we have adequate allergist demand to meet our needs now with burgeoning type 2 disease and with the growing population? You know, what do you think about that workforce wise in allergy? Okay. I was digging around to try to get a handle on how many allergists are out there. And since I'm in an institution that's a fellowship or even a hard number on how many allergy fellows there are, my belief, and I again, could be wrong, is it's the smallest medical subspecialty. I believe there's somewhere around 200 plus or minus, maybe 220 fellows. Does anybody have more hard information on that? Does that sound about right? 220, 230? Okay. So is that enough workforce wise for us allergy wise? Okay. Something important to think about because it has directed impact on your future. Okay. To the good, there's plenty of work. To the challenge, what about the people that we care about? Who's going to provide the service? Okay. So what about ENT land? I make us look really good because here, oh, this is this dated picture and it's from 2000. We didn't do one from 1999 until 2022 either. Okay. And then we had the workforce together, which I'm foolish enough to sit on or to volunteer on, if you will, right? So we had the pieces in place, and we're like, okay, well, let's do it again. So we did 22 and 23. We're going to move to not as frequent as a cadence per se because it's a big lift, but we're doing the same thing, and we've got the exact same conclusions. There's not enough of us, okay? Not only that, besides not enough of us, there's also distribution problem or piece, okay? Here we are in a lovely city. Like I said, I love it here. I applied. I trained. I didn't tell you guys about myself. I'm in practice in Pennsylvania, and I'll tell you more about my practice in a bit. But looking pursuing residency myself, I applied. I ranked UW #1. Okay, and the ENT department here at UW has a very strong academic bias, in my opinion. I believe it still does. And I was certainly going out into private practice. Okay, and they had me sniffed out. They probably figured it out that I'm not going to be choosing to go into research, right? So I didn't match out here, but that's okay. You make your choice. But why would I want to come out here? Okay. there's enough Asians in this town. They don't need another. Okay. Why would I want to come out here? It's an urban area. It's a beautiful big city with fantastic food and an incredible intellectual community, an academic community, and an entrepreneurial community with amazing outdoor activity. I don't have to tell you guys. Okay. But what about Eastern Washington, right? The whole whammy concept exists for a reason, right? So it's not just workforce, it's also the distribution. In ENT, and I don't have this information on allergy, but in ENT land, we have an overabundance of subspecialized otolaryngologists that want to practice in an urban environment and a startling lack of ENTs that wish to practice comprehensive or general ENT in community settings, right? And that sets up this disharmony when you look at the workforce. Who's putting out workforce reports? It's not the docs and the providers in the community. It's the academics, right? You're going to publish and do this and that, right? So this perception, oh, we've got plenty. There's a lot here, okay? Versus out in the community where you can't recruit anybody. So workforce implications are substantial. Whether you think whatever you want to do, think about that because it's going to show yourself a pathway forward, okay? So very similar circumstances, right? So again, looking to the future, how does that impact you? What are some of the things that I see that are a result of this workforce-wise? If we don't have enough physicians in allergy and ENT. Well, are there nurse practitioners and PAs in the UW allergy team? I looked at the website. I think I saw one. Okay, right? I think I saw one. And when you look at the workforce stuff online, if you poke around, there's these reports. Oh, this is Allergy Partners. This is the biggest allergy group in the country. This is family allergy. This is the next biggest one. To me, gang, the future, we can't do it by ourselves. Okay, right? So is it a degree? Is it a title? Okay. Is it a specialty? It matters. Training matters. But to me, it's the person, their ethics, their intelligence, their integrity. Okay. Their training, their collaboration. In my practice, we can't get it done without APPs. Okay. So that's one of those things. And I don't know the thought process, whether it's deliberate or accidental, behind why you might have any particular number of APPs or not. But to me, our future in healthcare doesn't work without more provider help, okay? So to me, the metric isn't how many docs in your group, it's how many providers in your group, okay? People that can see and render care. How can you extend your skill set? And if you're concerned about someone, I trained all this time, and someone's just going to go through a program and go directly out into practice. They can't do what I can do. This is wrong. This is inappropriate. If there's someone that's talented enough to approach your skill set with less training, you know what you should try to do? You should think about yourself and what you have to offer, okay? And you should also try to hire them, okay? So workforce-wise, I think, APPs are a key component. What's the largest ENT group in the country? It's not an ENT group. It's ENT and allergy. Approaching 300 physicians. They don't use APPs. So I'm going to say it out loud, and I sent it to the president on Saturday. I think it's a giant blind spot. So the largest ENT group in the country is, on their allergists alone, would qualify as the third or fourth largest allergy group in the country, okay? They have over 200 ENTs. They have over 60 allergists, okay? So, I think this is our future, and there's something to think about that future if that group is a group of ENTs, allergists together, okay? So what about some other things? Oh, now we have let's see if I can get this going again. Good, okay. Whew. Like I said, live by Zoom, die by Zoom. Okay. So what about other things? Practice. Okay. This might be a traditional model that people think about at our practices. Oh, I'm academic. Oh, I'm private practice. Does that same paradigm really apply in allergy? Right? Either private practice is either or. It's either private practice or your academic. I'm sorry for the guests here. The academic was listed highest. Okay. But I think the practice models change, right? In ENT land, the fastest growing segment is non-academic employed. And I don't know if that's the case in allergy land, but because of this distribution problem I said earlier, there's plenty of hospitals across the country that don't have any ENT providers. So what do? They're going to be forced to hire, right? So they're going to hire so that's the fastest growing group. So is that academic? Not really. But is it private practice in the sense that you're the one writing the check? It's very much corporate. You're very much employed, right? So that's a different model. Even the old model of private practice, you can see I've got some subtitles there, subheadings underneath. There's solo, there's a single specialty group, and then there's a multi-specialty group. Okay, so which ones of those are relevant? Looking online, the large, I said Allergy Partners, Family Allergy, they don't have, at least on their website, any otolaryngologists on their team. If you're a team of 60 allergists, why in the world wouldn't you go hire yourself some rhinologists, right? Why would you outsource anything surgical or procedural? Why wouldn't you just hire them? Okay. So, in my opinion, this evolution to larger, okay, and then I'll touch base on that. But in terms of specialties working together, good things come from ENTs and allergists working together, right? I truly, truly believe that. You look at a burgeoning awareness of type 2 inflammation and the different manifestations of systemic process. I know that my patients do better if I'm smart enough to see a patient, or if I'm lucky enough to see a patient with nasal polyposis. And I'm not saying there's a perfect surrogate marker, but see an eosinophil count of 1,200, maybe I had to pull in my allergist before I think, oh, you failed maximal medical management. Let's go to the OR, right? So I know that care is better working together. So I didn't share that much about myself, about my practice. So in this context, I talked about ENT. I'm not that smart. It's imitation. So it's the largest ENT allergy group in the country, and I think it's successful. I'm saying, hey, does that apply to me? So my group is a group currently of 13 ENTs, 7 allergists, and we have a pulmonologist that focuses on sleep, or you could call it outpatient pulm, the non-critical care stuff. And as I said, I think our patients do better by that collaboration together. Another term that I'll use to describe my practice is privatemics. I was kindly introduced as a chief or chair of otolaryngology at a network that does indeed have residents, but I'm very firmly in the private practice world in the sense that I am signing checks now electronically, but you get the idea, okay? So we're this hybrid thing I call privatemics, where on one hand, we're a private practice, yet we're the entire faculty for a residency program of two residents a year, okay? And one thing that I know that our residents get is probably more about the business of medicine than most other traditional residents do. So I think if you're going to be in this environment training here, you ought to take advantage of what your particular programs have to offer. So if it's a chance to collaborate with the business school or other departments or any entrepreneurial innovation pursuits, I think you're in a rich environment for that. And I would try to take advantage of that, as I did coming out for CDL here at the UW. Okay. So these trends for the future: workforce, practices. What about this? Okay. What about this? My mother, I guess it's not a was, right? If you're an Eagle Scout and I'm not, they'll make a point of this. Oh, it's not like someone was an Eagle Scout, it's someone is. It's like a lifetime thing. So I'm just about to say my mother was a physician. I guess it's appropriate to say that she is still a physician, although she's not in practice. That's a whole something for us to think about too. Who do we become when we retire, right? If that's our identity. So my mother is a physician, although not currently practicing. And growing up, they didn't throw out anything. That could be an issue too. But there's like stacks of magazines around. So I always remember seeing Medical Economics as a print magazine. Medical Economics went out of print form in 2016. It's still out there, okay? But this is a picture of a cover from 2019, November 25th, 2019 of Medical Economics, no longer in print, but that e-format is there again for those who wish more of an education about medical economics. There's still some pretty rich content there, okay? But this is their cover. Private equity is coming. Why investors target medical practices, the pros and cons of taking an offer, okay? To me, I don't think all private equity is wrong or evil, because we need access to capital if we're going to do things, whether it's from a bank or a larger level. But I do think that looking at some of what's going down with private equity in the healthcare space, I think we could argue that to a certain degree it's extractive, right? That's a basic premise. What do you want? You're trying to get the money out. And maybe the patients and the docs don't necessarily flourish in all circumstances, but what's behind Allergy Partners? What's behind Family Allergy, right? There's 7 platforms in the ENT space. In 2019, there was exactly 1, right? So right now there's 7 practices in ENT space. What is the implications for this, for our future? Like it or not, it's going down hot and heavy. And now capital markets are a little different at the moment, right? The money's not as easy. Maybe there's no exits to put a brakes on things. But this is a big force in our specialty as well. And I think to a certain degree, both allergy and ENT are still somewhat fragmented or cottage. So I think this could have a big impact on our future. So workforce, distribution, thinking about the nature of practices, other external forces driving change. These are things that are going to make ENT and allergy in 2030 look differently. And I'm not going to predict exactly what I think it's going to be, but some of these things I'll take that bet, right? We're going to have more collaboration between ENTs and allergists. Net overall, there's going to be larger groups. There's definitely going to be more utilization of APPs. I think these are pretty clear trends that do not take that much to foresee or predict. Okay. So that was some on workforce distribution. So what about technology, right? I was talking about the workforce piece when those studies were done and what did tech look like there. You're in a hotbed here, but I think talking about technology a little bit is fun. And when I connected with Len and I threw out some topics, one of the other ones that I threw, we're talking about some of these newer things out there. And so I figured, well, since I had the freedom to talk about the future, I can probably weave a little bit of that stuff in this particular presentation. So a quote I really like. Any sufficiently advanced technology is indistinguishable from magic. Okay. So it's Arthur C. Clarke, the science fiction author. Who can turn their lights on at home or open their garage door from right here? Right? Okay. Or change the temperature, unlock your house right here. Or order or have food show up at your door right now to your home, wherever it is in the greater Seattle area. That's science fiction, right? 50, pick your time frame, 10 years ago, 15 years ago. That's science. Who could get in a car without a driver and take you somewhere? Okay. That's science fiction a couple years ago. But everybody here, particularly on this coast, knows it's not. It's reality, whether you embrace it or not. Okay. So technology is very, very interesting to think about what's conceivable and what can be done. And there's going to be big impact on how we practice from that going forward. So I'll spend some time, maybe about 15, 20 minutes talking about new techs and things. So diagnostics, and it's just a framework for discussion on things, diagnostics, targeted therapies, right? Okay. And what does that mean? I'm not sure if there's a clear definition, but we'll touch base on that. Non-surgical interventions. Surgery's crude, right? I'm going to look at I'm going to look at a physical manifestation of inflammation. I'm going to look at nasal polyps. And just by the appearance of this edematous tissue that's changed, that's going to be the diagnosis and the descriptor that's going to drive how I manage that. I'm going to cut it out, right? Because I can cure inflammation with a knife, right? All right. So surgery's pretty pretty crude. Okay. So non-surgical interventions, I think this is going to be interesting going forward. And then more targeted surgeries or treatments in terms of what we're going to be doing. These are all things that are going to happen, and it's going to be more clear over the next 5 years. So what about diagnostics? There's all this buzz about precision medicine and targeted therapies and personalized care. And we can't do that without better diagnostics. I use an example where our specialties overlap with nasal polyposis, right? Okay, 87% of folks in the Western world, the US and Europe, with nasal polyposis have it driven by type 2 inflammation. But even the pattern of saying type 1, type 2, or type 3 is pretty crude, and there's significant overlap, right? So there's a lot that we don't know. So we need better diagnostics, whether it's things like nasal polyposis. From the ENT side, how crude is it to describe a cancer based on where it's located? You have squamous cell cancer of the oral pharynx, because all of them that turn up in the throat are the same, the ones from smoking and drinking versus ones from HPV. So we need better diagnostics. And going back to reporting 101, right? The who, the what, the where, the when, the why, the how, I think is a useful exercise when thinking about diagnostics. So in allergy and immunology, what are some of your foundational diagnostic tests, right? And there's more than one, but I'm going to use allergy testing in this example. Okay, so who are we testing, and who's doing the testing, right? One of the choke points: allergic disease is underdiagnosed, right? Okay, why? Because they got to get to y'all for testing, right? So the testing that you do, what about the in vitro testing, the immunocap or otherwise, right? So if allergy testing was more readily available, if it could be obtained by other means, if consumers could do it themselves, would it result in better care? Okay. And then the same thing, what testing? I'm using allergy testing example, but where? What about point of care service? Is it conceivable in this world that patients could self-diagnose allergies themselves in their home? It sounds crazy. Maybe people are going to say, oh, there's no more job for allergists and some ENTs. But to me, if you have an identified disease, what are patients all going to self-treat and self-manage? Okay. So it's very interesting to use this framework to think about diagnostics. So I use a parallel because I want to be careful. Right now, I think one of the furthest examples I'll use a couple further things to think about. Sanofi and Regeneron are gracious enough to welcome me out to chat with colleagues last night, right? And we know in this space with targeted therapies, the biologic, the monoclonal antibodies, there's plenty on label for pick your disease state, asthma, nasal polyposis, atopic dermatitis, the list goes on. But if we're going to figure out why would you pick one targeted therapy or one particular therapy versus another one? Which patient's going to respond to this intervention? Because there's a value piece there and an efficacy piece there, right? Okay. If we had a diagnostic test that said this person's going to respond to this intervention, what would that do to our confidence in terms of prescribing it for a patient and their willingness to embrace that therapy? What it do, and this is America, so follow the dollars. There's people less concerned, big interest, less concerned about waste than we might imagine. But I'm concerned individually about waste. How much more efficient would it be to not start a therapy and have it not work and go into another thing? So I think there's a lot of room for innovation, diagnostics. Diagnostics are the opposite of sexy. Okay. And the truth of the matter is there's some glowing examples and, companies out there that had all promise, no reality, right? So there's a stigma on it as well. For the money out there, it's not nearly as exciting or as interesting or as quick as tech in any one shape or form, but we're going to have better diagnostics in the next 5 years for sure. Okay. And it's definitely going to change our practice. Think about things. What's our companion diagnostic? You look at rheum or you look at other specialties. What's our companion diagnostic to say this therapy is working? Okay. We're using patient reported outcomes like the SNOT 22. Okay. I'm never on time. This morning was a good example. Okay. If I'm late in the office, how do you think that impacts the SNOT 22 the patient fills out? Right? If you get a quality of life test and you're given to a patient and you're an hour late, knock off 5 points, knock off 10 points. And it's only a subset of us that are more academically inclined that are going to use a patient-reported outcome. How about an objective test that would actually show response to therapy and you use for disease state monitoring? Okay, so we need these things and they're coming. Okay, all right. So targeted therapies, I mentioned some of them. I'm the surgeon, so I'll play the meathead card. Back in medical school, that slide would come up and it was like the Rube Goldberg picture of the inflammatory cascade with all these arrows and steps and all these IL whatnots and this and stuff. And I promptly fell asleep. Or maybe I didn't attend that lecture because there wasn't, cutting and fixing things involved in the directed fashion. And I'm purposefully being, I'm stating this a particular way on purpose. But the other reason is what was our means of treating or changing that? You could just carpet bomb with steroid, right? Or just blast it. That's it. Or maybe block this one chemical messenger here, histamine, right? Or now the leukotriene inhibitor. Okay. Now that giant map with all these steps that are mapped out. Okay, we know 4 and 5, these alarmins in 25 and 33 and TSLP, and then these changes in these cells and okay, ILC2 and then TH2 and then IL4 and 30. Now we have the targeted therapies, right? We have a whole library about them, more than most of us even know about. I think our industry partners out there are smart enough to build out the libraries of monoclonal antibodies. It's just which ones do we choose to work? What do we target, right? To the good, this is where the clinical trials come in to figure out, we think this one's going to work, and you got to run the trial and find out whether it works or not. Why do some of these agents have approval for asthma, but not for another disease state where we know there's overlap, right? 50% of patients with nasal polyposis have asthma. Why does this work for asthma, but why didn't it meet endpoint for nasal polyposis? Was it just study design? We don't know for sure, okay? But right now, I don't think any of us need to question whether there's additional targeted therapies out there. There's going to be more and more and more and more. And if there's any surgeons or listening in, if there's any ENTs listening, you may not like it, but we are definitely going to have less surgery. Okay. If I had a better diagnostic and I could look at a patient and said, this person's not going to respond to surgical therapy, very few people are going to choose it. And very few physicians should choose it if they were thinking about treating their patients as if they were their families. So better diagnostics and targeted therapies, this plus the piece that I skipped over, the machine learning, the AI, looking at the outcomes, this is going to drive more personalized medicine for sure. So I really truly believe we're in a golden age right now. It's not necessarily recognized because we're the people in the trenches dealing with workforce concerns and burnout and yada yada and admin and all this sort of business. But we're going to have great tools coming forward to the good. And I'm not thinking it's going to be 20 years. I'm going to say it's over the next 5. Okay. All right. So a couple minutes on some fun stuff that's newer. What's the space between medical therapy and surgical therapies? So what about non-surgical what about non-surgical interventions? Okay, and if you go to the dentist and you have a filling, or let's click it up one notch and say a root canal, right? Did you go home and say, man, or does anybody saying, I got surgery tomorrow? I had surgery. Okay. Oh, I went to say to my family, oh, I have surgery tomorrow. I'm going to the OR. If I'm going to the office to in-office cases, even as a surgeon, I don't think about I'm doing surgery. I'm doing procedures, I'm doing treatments. Nobody thinks root canals are surgery, but next time you're getting one, you're like, yeah, this is surgery. Okay. All right. Right. So it's interesting that space in between what patients think about. But so I have both something that is definitely not medical, not surgical procedure at all, acoustic resonance therapy, and I have one here that is a treatment per se, posterior nasal neurolysis. So touching on these. So, what are things that are out there that could work that sound like science fiction, right? So there's this I'm going to struggle with the pronunciation, so I'm going to leave it to the slide. Brahmari pranayama that's listed. So the Western translation is humming bead breath technique. Okay, so this is an Eastern practice that can be done where you're humming, okay? And this is the historical basis for acoustic resonance therapy. If you go ahead and look up Pranama Brahmari. Again, I apologize to the people virtually. Since it's blocked, I'm going to walk over here. Do you have it? The virtual piece. Oh, there, I can see there. So Brahmari pranayama. My last name's Yen. That's too many syllables. So Brahmari pranayama. Okay. So if you look that up, actually, the historic basis of this treatment, it's actually not just acoustic resonance. Okay. There's also a rhythmic breathing component. Okay. There's also some sensory deprivation. You're closing your eyes. You get your fingers on your eyelids. You happen to have a finger on the first branch of trigeminal. Okay. And during it, you're actually compressing your nasal valve externally. So what's that called? That's called PEEP, right? Positive and expiratory, and expiratory pressure. You're exhaling against resistance. So actually, if you look at the historic basis, it's very, very interesting. This therapy here, though, was the basis for, all right, is there some validity to this and how, right? Okay. So, nitric oxide, all right, what's that for? Who would imagine that it's a chemical messenger and it has a role in our body, right? With vasodilation, with other things. So here, there was a Nobel Prize awarded for the recognition that nitric oxide could play a role, right? But for our respiratory system, increased mucociliary movement, antibacterial, antiviral effect, and anti-inflammatory effect, right? It's fascinating. I'm going to shout out to another friend's body of research, Noam Cohen, who's at the University of Pennsylvania. A lot of his focus is on bitter taste receptors, right? And all this stuff sounds like fantasy, like, quorum sensing molecules. But, bacteria can communicate with themselves to function unison to form biofilm. So they release these molecules called quorum sensing molecules that communicate with each other. And humans can pick it up, right? Bitter taste receptors can pick it up. It's not an accident that quinine in tonic water as a bitter agent has some antibacterial effect, okay? So there's plenty of things that we don't know about that seem like science fiction, but nitric oxide is one of the mechanisms we think behind why acoustic resonance therapy may be effective. So This is all the way back 22 years ago, not so new in terms of publication. But just in brief, human humming results in a 15-fold increase in exhaled nitric oxide compared to just regular breathing. So if we hum and we get more nitric oxide in the nasal cavity, can that improve our symptoms, right? You folks know on your end, of course, fractional expired nitric oxide from lung. There's no commercially available test to look at that from the nose, right? And there's another piece here to think about too. Why is a very useful diagnostic test that costs $9 really not widely utilized in healthcare? To say to someone coming with a cough, wait, you're going to go on all these medications and see all these doctors, but we can measure this for 9 doctors. And if your pheno is above 25, maybe I got to ask for help from someone on the allergy side, right? So even though things are out there commercially, it doesn't necessarily mean they work. But nonetheless, nitric oxide for measurements of acoustic resonance, also from the common sense perspective, okay? What do you do if you had a tray of tater tots, okay, and you wanted to get them off the tray on the plate, okay? This is my simple guy explanation of acoustic resonance therapy. What do? You shake the tray, okay, right? You're trying to get bird food out of the bag, you shake the bag, okay? So is the acoustic resonance of the vibration itself thinning the mucus and allowing for clearance, okay? And then this other piece here, okay, what about autonomic neuromodulation, right? The sphenopalatine ganglion does a lot more than we might recognize or realize. So this is looking at using acoustic energy to treat pain, okay? I had another attending that left this mark on me that said, if you treat pain, you get pain, okay? And I think there's some truth to that. But if you look at what's the number one cause of disability for working age adults? Migraine, right? That's crazy, okay, to think about. Think about what we could do if we'd be more effective at treating migraine, okay? Then, like, it's not just, how people feel. It's days of life, it's work days and so on. Number one cause of disability in working age adults, okay? So wait a sec here. Sinus inflammation is a neurogenic component on a dysfunction. So right now, vibration acoustic energy has been shown to modify neuromodulation, reduce pain. Could we potentially use these therapies to treat pain more effectively? Okay. So I think there's some hints of some impact or effect here, something to think about, but it's fun to think about these things, right? There's a historic basis. Again, if you want to look at them, try it. It'll take you the bee breathing technique, it'll take you a minute. It's 5 cycles of breathing. So it'll only take you a minute. So if you're really bored in a minute or two before I wrap up, you can try in the background and see whether it works for you. Okay. But it's interesting to see how these historic things might be brought into the future as we understand the science and have new tools to work and treat our patients. Okay. So acoustic resonance therapies out there. There are 2 commercial players in the space. I'm not saying their names. I'm happy to chat about with you them after, but there are 2 commercially available modalities for acoustic resonance therapy, right? So autonomic modulation, just this diagram, I mentioned the sphenopalatine ganglion, okay, right? So an old school diagram showing the innervation, the nasal cavity, where it comes in. So you can get at this in the back of the nose, right? And so what about going there directly to treat? Okay. So there's different cultural standards and behaviors and what's accepted in different cultures. To be a snotty, runny nosed little kid is a lot less tolerable in Japan than it is here in the US. Okay. Or really in Japan, other parts of Asia as well. And so when it comes to posterior nasal nerve sectioning or video nerve sectioning, when I was training, one of my attendings was doing a video nerve section, and he was going back there, and it's a lot of surgery, and you're drilling out a bone to get back there, and if you get the video nerve, you're preganglionic, so you can end up with dry eye. So I was like, I'm never touching this surgery. I'm never doing a surgery. A very complicated, difficult surgery with a chance of dry eye and terrible complications with no code for runny nose. Who's touching that? That doesn't make sense, okay? But culturally speaking, it's a lot less acceptable to have a runny nose, like I said, in certain places, Asia. So video nerve section, posterior nasal nerve ablation or section was still being done in Japan, even in children, okay? And there was a body of literature looking at cryoablation out of India, using cryo to get back there. And, if you think about energy tools or modalities, if you went to the nearest Walgreens or CVS or whatever the local is here, what kind of treatment tool can you get? Can you walk in and buy a syringe, or a scalpel or any prescription medication, right? You can walk in and buy Dr. Scholl's Ward Away, right? Okay. So cryoablation is not unfamiliar to patients. It's out there. It's something that people get and understand. So, what about going back there and freezing? Okay. And so friends of mine looked at this information from India and said, wait, what if we can make it reliable and reproducible? And that's the body technology you see on the side, looking to use it cryoablation to accomplish posterior nasal nerve ablation. So that became commercially available here in the US in 2016. And that was the start of saying, wait, we've got other ways to target the nerve, and what does it work on? Okay. So my individual journey from the clinical perspective with this is saying, oh, this is going to be effective for runny nose. There's data over the years, right? So you've got patients in your population. They're appropriate for desensitization, but they've got bothersome runny nose. Yeah, well, there's a therapy now that's on therapies or treatments, different tools under local in the office, FDA cleared, Medicare covers. Okay, so this is not science fiction. That's out there to help your patients as a nice adjunct. Please. So this is a great question. So I'm going to talk about all these treatments as an overlying thing. We're looking at extensive real world experience since 2016. No evidence, okay? No evidence of increased risk of infection or anything like this. As a matter of fact, in the public domain, in the public domain, which even it seems like I can talk about, okay? There was a clinical trial run looking at posterior nasal nerve ablation specifically geared towards not just rhinitis, but specifically geared towards chronic sinusitis. So instead of saying, wait, historically we knew if we treated posterior nasal nerve ablation, okay, if we did this, it might be effective for rhinorrhea. Okay, but what about nasal congestion? Okay, so there's good evidence in the published literature, about 85% response rate to these interventions with about a 50% reduction in nasal congestion and rhinorrhea. In the published literature right now, we start to say, hey, wait, what's the overlap? So some evidence that we just published that eustachian tube dysfunction, right? Okay, because I had a patient, and this is how we can individually make a difference. I had a patient who happens to be the father of one of my PAs who I treated. And he came in and said, scuba style clearing of ears no longer necessary. And I'm like, okay, if we have eustachian tube dysfunction, what's anatomical and what's inflammatory? If children with allergies are more likely to get otitis media, I think there's an inflammatory component, right? Okay. So if I treat something that results in impact and congestion in the nose, okay, and decreased mucus production, could that be effective for eustachian tube dysfunction? So we included one PRO on a LARC, the EDTQ7 on a clinical trial, and lo and behold, statistically significant evidence. So it's just a little piece of information, okay? But this piece, same thing in the published literature, this intervention, now there's 2 publications showing impact on postnasal drip. That's a whole nother story, gang. What is postnasal drip? Okay, is it a physical finding? Is it a symptom? Right? It's poorly described. 0 PRO for postnasal drip. How can we even look at it to say if we're going to work on it to see whether a patient got better or not? Okay, but there's 2 studies published now looking at people undergoing posterior nasal nerve ablation specifically for the indication postnasal drip. And lo and behold, the same success rate as people choosing it for rhinorrhea or congestion. Okay. So I would urge you to, on your own, if you can, or we can chat about it otherwise, or I can share articles, or you could dig around because there's plenty of stuff out there now. The initial thought process in 2016 was, and my own, this is going to be effective for the runners. Okay. Rhinorrhea. I didn't think it'd be effective for the blockers for nasal congestion till these people are coming in. You're like, oh my goodness, you look decongested. Okay. So for you guys as an adjunct to your practice or our practice together, this is not the old school, oh, go see the ENT. Don't go see the ENT. They're going to scope you, operate on you, and your symptoms are going to come back. Or, don't go see the allergist. They're going to allergy test you until you get rid of put you on shots until you get rid of your cats and your carpet. Okay. We work together, and this is a good example of that. So you're initiating someone on desensitization, and what's the ramp up period? If there's a therapy that's going to work for a couple years, it fits in nicely collaboratively because you can knock down the symptoms, and by the time these things might be wearing off, fantastic, then their desensitization more effective. Okay, so this is a very, very interesting space to think about where things work. Different modalities with cryoablation. The middle one's using temperature controlled radio frequency. This one here is using impedance controlled radio frequency. My opinion, we're scratching the surface with this particular intervention, right? So All these are, on label to treat unwanted tissue. That's pretty broad, okay? To treat chronic rhinitis, that's pretty broad. Describe what chronic rhinitis means. So even without formal labeling, you can talk about treating postnasal drip or these, because, is that a component of rhinitis, okay? But the story is untold here, and we're going to see more in the way of literature and evidence over the next few years with this particular therapy, okay? So again, these things are out there, and in a broad sense, it's not just PNN, right? It's not just acoustic resonance. It's other therapies that are out there. I'll use the parallel in thyroid land, because it's a good parallel. Okay, better diagnostics. Wait, that nodule by molecular diagnostics, we might have called it cancer before, but if we have information about its behavior, if it's not going to knock you off in the next 50 years and you're 50, are you really choosing surgery, right? Okay. So with better diagnostics, okay, what can we do to manage what we might have managed otherwise with surgical, and with better therapeutic modalities, right? Now with radio frequency ablation, already FDA cleared to treat benign nodules. So this combination of things. Oh, it's not just thyroid nodule, it's getting bigger, it's surgery. Well, what kind of nodule, even if it's cancer, can we watch it? Okay, if we need to treat it, can we treat it with a less invasive intervention? That's going down right now in thyroid land. Okay, so these are big changes with these new therapies, and there's absolutely going to be more. Some is getting a handle on as we have tools, whether it's targeted therapies. Why didn't this agent work for that process? Let's take the subset of people with nasal polyposis that don't respond to your preferred biologic and really do a deeper dive on them and figure out why they didn't respond. That's going to drive, with better diagnostics and better therapies, that's going to drive our learning and understanding and our ability to treat. Okay. All righty. So nobody has a crystal ball, okay? But as I started before, I said I'm not an expert in anything, and I've been wrong before, okay? And if you're, the whole purpose of this was to do exactly, to chat, okay? And I'm glad for the question, and I'm hopeful for more. It's to get us thinking about these things, the changing workforce, distribution pieces. What are we going to do? I'm not ignoring AI. That needs to be thought about too. Is it going to replace us? Right? I think most people feel that healthcare is more insulated, or it's not even right, less subject to completely being usurped than others, right? It's going to be a great tool for us that we're already seeing, whether it's ambient scribing or otherwise. But how is AI going to do allergy shots, or how's it going to? I'm not saying all surgeries are going away. How's it going to resect the head and neck cancer and so on? But it's interesting to think about those pieces too, how it'll influence us. Me personally, I think to the good, it'll mostly influence besides the diagnostic and therapeutic and the clinical piece. I think for the most part, to the good and bad, it's the administrative and the piece, right? Is it the documentation? Is it whatever your local Blue Cross Blue Shield or Aetna United using an AI program to deny your request for a patient for surgery or treatment because it looked in your note and point whatever milliseconds and returned a denial in 1 minute via fax? Okay, right? That's not, I don't know if you guys are encountering that, but that's like who's got the resources to bring big AI programs to bear? Not the allergist in private practice in a small community, right? But the Aetna's United States. So that's a whole another subject. So nobody is a crystal ball, but hopefully this prompted some thought, right? And maybe some questions. Okay, so. We were talking about the future. Just so you know, this is your special word that I'm supposed to put up at the end of the slide deck so the people joining virtually who are not UW can use this word to submit their evaluation. I welcome feedback, good or bad. You could say, "Oh, he's full of hot air and nonsense," but I think that's almost the definition. I'm not calling myself this, but that's almost the definition of a futurist, right? You're full of it, right? So at any rate, that's your code word for the day is the future. Okay, so. We have, everybody's got a busy life. We have about 10 minutes left for questions. This is a picture that I put up because there's just so much to unpackage here in this picture. I find it humorous, right? Because it makes me wonder, thus questions. For assistance, push 3-inch help button, right? And it's there in Braille. So the person in Braille can see where the button is, right? Like, okay, so that it matters that it's 3 inches, right? Okay, then you're going to stop to agree that when you see the big button below that says push for help. right? And I like these things here, like help requested, help coming. Again, our challenged individual with disabilities is going to notice that the red light lit up, that help is coming, right? So that, like, someone built this and installed it in a building, right? So I have a lot of questions about this. Okay. So does anybody have questions for me about what we shared? Disagreements, thoughts about the therapies, about the workforce stuff, about consolidation? Any thoughts, any comments? I hope, and I'll ask for help for somebody regarding let's if there's any from the virtual platform. Let's see. I don't see anybody's hands up here for a chat. Oh, excellent. Thank you. Please, and tell me a bit about yourself if you're willing. Ah, Hannah. Thank you, Hannah, first year fellow. Thank you. Sure.
Typically, for were they looking at those in patients who are otherwise immunocompromised?
Okay. So right now, to the best of my knowledge, there's talking about what's in the public domain. So there could be some stuff going on that I don't know about, again, because I'm one person. Okay. But the one study that was done, if you look at PNN, much of it earlier on focused on chronic rhinitis. And because there's some question about how effective this therapy would be for people with chronic sinusitis, if you have another mechanism, infection per se, driving inflammation, how effective is going to be taking out the nerve, right? Okay. So all the studies that went down to date specifically excluded chronic sinusitis, right? So this particular study was a pilot, and looking at this to explore from the science perspective, let's specifically wait a sec. Let's specifically look at the population that has chronic sinusitis. Okay, so think about the book definition of chronic sinusitis. You got a bunch of us in a room a couple decades ago saying, how are we going to define chronic rhinosinusitis? Well, do we agree it should be 12 weeks? Okay. Who's the expert here? This is not fact. This is people rendering their learned opinion. Okay. 12 weeks of two of the four following hallmark symptoms, right? Nasal congestion, right? Discharge. Was it clear or mucopurulent? Not specified. Sinus pressure, right? Okay. And alteration in sense of smell. So therefore, COVID's not necessarily 12 weeks, okay? But wait, you don't have all those symptoms, sinus pressure, congestion, discharge, like with the virally driven process. Allergies, you have allergy symptoms in springtime. It meets the definition of chronic sinusitis. It's garbage, okay, right? But it's the best that we have. So objectively speaking, what would you pick if you were to look objectively for sinusitis? You'd pick CT criteria for inclusion. Okay. So you're going to specifically include people that have objective burden besides the medical definition with words. Okay. You're going to look for a particular burden of disease on CT scan, and you'd probably want some degree of PROs that are in line with that if you're looking for change or improvement. Okay. To the best of my knowledge, no specific look or subsegmenting its subpopulations based upon immunocompetence, which is a great question, Hannah, particularly for an immunologist, right? Because if you get combined variable and whatnot, okay, you've got another mechanism for your sinusitis that's not anatomic alone per se. And how much is Neurent going to work on that? I don't know. Okay, I wouldn't think so, right? But there's stuff out there. Okay, on label, we know that there's Neuromod for sleep apnea. We know there's Neuromod for depression. We know that they're in study, not commercially available, but talking about science and study, could Neuromod work on depression and rheumatoid arthritis and all this other stuff? Do you know what I mean, right? So it's interesting to think about. But for that particular, no formal short answer, no formal look at immunocompetence in that particular case.
Came to patient community recurrent sinusitis, multiple antibiotic courses per year. We've already tried. They're on immunoglobulin.
Sure. I would not do this procedure. I would not pick this procedure on that patient as a standalone, because to me, if an algorithm to approach this patient, why does someone keep getting sick? And if you look at the things that contribute, you're saying, okay, the primary piece here may be the immune function, okay? But then the other things that are there, the nature anatomically of sinuses, we're dealing with a small, narrow space, okay? Right? So it's old school, but dilution is the solution to pollution, right? So in a particular case like that, if we're dealing with a recurrent process, I'm going to want to change the conditions to make it easier to manage. So I think the approach in there is full house fess. Okay, get the sinuses open. It's crude, but if I took the lid off the honeycomb, you can wash it out better. So now I'm empowering my patient means for local drug delivery with steroids for inflammation. The data is soft, but it opens the door potentially, if you believe in it, for topical therapies with antibiotics. Okay, but if dilution is the solution to pollution, I can help reduce bacterial counts and viral counts with irrigation. So I think in that case, with that person with recurrent disease with CVID, I think there's a role for surgery just because you make it easier to clean. Okay, all right, versus this therapy. Now, the great question, is it an or is it an and? All right. So if you're treating people, so I've had patients that I've done what I feel very happy about. Good sinus surgery for nasal polyposis, and I've rendered them polyp-free. Oh, I'm a good ENT. I got this patient polyp-free. Yeah, and then they still have rhinorrhea and congestion. And then therapies come along 8 years later, and I'm treating them, and now they're really happy because their nose isn't running as well. So I think some of this is not an either or. So in a broader perspective with new therapies and new treatments, and again, these are some of the things focusing on surgery, but if you look at, for example, nasal airway obstruction, from the ENT perspective, okay, and this is relevant, right? Oh, no matter what I do, this person has obstruction congestion. You guys are not moving cartilage and bone. That's fact. Oh, so the allergist might say, go see the ENT. You've got a septal deviation, okay? And we're thrilled to see that. But an allergist sending a patient to ENT for septal deviation saying, you're hungry, go get meat, okay? Because septoplasty is meat and turbinate is potatoes, okay? And in today's day and age, why do I love Seattle? Because think of the range of things that you can eat. Okay, so now it's tapas or dim sum. Okay, or sushi. You pick which thing do I want for nasal herbs. Now I've got valve work, I got turbinate work, I got septal swell, I got PNN. I got a range of tools and treatments. And this is what I'm getting at with in this case better diagnostics. What is actually driving this patient's complaint? What do they mean when they say congestion? And how do I best fix it? Okay, so short answer, PNN for that patient, no. But could I make the argument if I believe that a surgical intervention is relevant in this case? And I do, right? I've had it. I'm doing all the right stuff medically. Make it open so that I can at least wash the junk away, right? Okay. If it's bad enough to engender OR risk, anesthesia time, and this therapy can be done on top of it, what's the incremental cost? What's the incremental risk, right? Okay. So I'm not going to claim individually that I think a treatment to neuromodulate is going to be effective to treat all chronic sinusitis. No, there's no way, okay, right? Because it doesn't treat CVID, it doesn't, okay? But patients don't come in and talk about their Lund-Mackay score. They talk about their congestion. They talk about their sinus pressure. And if, bee breathing technique improves that, it might not be a cure, but we ought to be open-minded about it. If these other therapies improve it, we ought to be open-minded about it, okay? So I like the way that you're thinking, Hannah, okay? I really do, okay? Other questions, other thoughts? Please.
That patient would have changed.
It's a whole nother story. That patient, heck yeah, okay? Because this is the thing. This is your other option. Suffer. Go and buy more Kleenex, okay? Right? Okay. So with shared decision making, I call that common sense, but the modern term is shared decision making. You have persistent bothersome symptoms in spite of all other interventions that we've undertaken. There's an on-label therapy for rhinitis, which is what? Inflammation of the nose, runny nose. There's no book answer for it. You've got persistent symptoms, and we've got on-label therapies with thousands of people treated with a pretty clean risk profile. Okay, that out there. I some of my most happy patients. Why would you do a procedure on a 93-year-old? It must be driving them nuts. Okay, right? So that person we can minimize is just runny nose, but you don't understand the difference in me. And some of the chronic cough peeps that have been through it with the pulmonologists and you folks and the laryngologists, and everything else has been exhausted. Okay. One of my worst, our practice's worst cough patient, P&N got across the line. And I don't think that's because it's just what additional difference maker got him below a particular threshold. Because the allergist in my practice, the good Dr. Carney, says it's like a bucket. There's all these contributors. And then at some point it gets to the point that the bucket overflows. So we're trying to control all these contributors just so the levels below where it, spills over into symptoms. So that patient there with symptoms, absolutely. Okay. So we're, and look, I'm going to plug Greg because he's the one who connected me with you folks. I'm friends with Almirati and plenty of the rhinologists, the UW, plenty of the ENTs at UW as well. But check in with them. Okay. So these things, they're good tools and they're getting better and there's going to be more of them. Okay. All right. Other thoughts, other questions, other comments? I want to really thank you all for taking the time to welcome me here. I want to apologize for the technical difficulties, but what are you going to do? We got through it, more than got through it. Here. I'll try to get him a sec. If you need to get a hold of me anytime, you can tell I'm terribly shy. So I'm trying to get this. So I can share it with the team thing, which the next slide had my email, my mobile number. But through Dr. Altman or anybody else, if anybody's interested, I'm always happy to be engaged with colleagues in discussions and learning and listening and thought. So please do reach out. I'll make sure I get my contact information to Dr. Altman and the team in case anybody wants to carry on from here. Okay. All righty. Thank you all. And the future was your word, right? Good. Oh, there's one here in chat. Shoot. So we have one on chat if it's still live. So Vinod, I apologize. I didn't shut down. So we had one on chat. Vinod was asking for, I know we're post time, but I don't mind. Vinod was asking, why should kids need a traditional college, medical school, et cetera, anymore? Do we need to train to ask AI the right questions? Thank you for your stimulating thoughts. I think this is a really great question. Okay. At what point do you trust something more than another human? And I think that's a leap, if you will, that's different for different people. Okay. So I'm going to use the driving example. All right. Everybody who thinks you're an average driver. Okay. Nobody thinks you're an average driver. Okay. There's some that'll admit, oh, I'm a terrible driver. But most of us think we're an above average driver. Most of us are wrong. Okay. All right. So we're not great drivers, but when do you trust technology to drive better than you? There's a leap there. Okay. So the human component, look about the plane. Are you getting in the car that's driven by autopilot? Maybe, right? Some do, right? More so it'll happen. Are you getting on that plane? Are you getting on that plane that's just on autopilot? Okay. So right now we're in the business of caring. Okay. And I think that AI tech, it's out there. It can provide some comfort and some caring support. But honestly, it makes a difference, physical contact, shaking someone's hand, looking in the eye. Okay. Are you going to procreate with AI? You know what? There's going to be some fluids in physical contact. Okay. So humans are necessary, right? So in terms of caring contact, if you're going to deliver bad news, did you want to hear it from a simulation that you'd cancer? Right? Where's the sympathy? Like it or not, I'm gut punching every day in the office, dropping that on somebody. And I don't like it, but I'm here to help. Okay. So yeah, I do think we need to send kids to education and maybe more of it. It's just, what are we educating more? I think most of us could deal with more education and caring and interpersonal skills and teamwork. So some aspects of this traditional college or medication, this rote old school memorization on pharma, like really, I think that the understandings are, no, it needs to be highly altered or changed, in my opinion, but we still need it, Vinod. So very, very, very good question. Okay. And there'll be a delay in that. But we do need to change it, but it won't go away completely, in my opinion. Okay. Thank you all. Be well. I'm sorry I missed it to the tail end. Thank you for the question, Vinod. I appreciate it.